Okay, so our agenda today will start with the CRI overview. And for those of you who have been to one or more of our presentations, forgive us. We're trying to give the CRI overview for all the new people. We'll go into the presentation, and then as I said, we'll go into the question and answer. Next slide. Okay, so um, the mission and vision of CRI are listed here. Um, our mission is to conduct community-centered, rigorous cannabis research that fosters public understanding, informs policy, and promotes equity. And we do this through a collaborative, interdisciplinary approach that turns science into impact. Our vision, let me take a step back here. And so our mission and vision were painstakingly arrived at by meetings that we held with all of the participants in CRI, or participants, meaning those involved either directly in CRI or as affiliates to CRI. We'll introduce some of the people later, I think. So our vision is to be the leading trusted institute for community-informed interdisciplinary cannabis research by setting scientific standards, informing policy, and advancing equity and sustainability. So I'm going to start with the introductions now. So the first of our two panel members is Leslie Mendoza Temple. She is the Owen L. Kuhn Endowed Chair of Integrative Medicine. She's also the medical director for the Integrative Medicine program at Endeavor Health. She's a clinical professor of family medicine at the University of Chicago Pritzker School of Medicine, a fellowship in integrative medicine at the University of Arizona under Dr. Andrew Weil. She's has a fellowship in family medicine and faculty development at Northwestern University Medical School. She's been twice appointed as the Illinois Medical Cannabis Advisory Board chair, 2014, and then most recently in 2024. And integrative medicine clinician combining Western medicine and evidence-informed complementary therapies for patients with complex chronic conditions. Our next panel member is Adi Haramati. And Adi, if I have not pronounced that correctly, please feel free to correct me. He's an award-winning professor of integrative physiology and medicine at Georgetown University. He's the founding director for the Center for Innovation and Leadership in Education, co-director of the graduate program in integrative medicine and health sciences, with over 40 years of teaching physiology and advancing health professions education, national leader in human flourishing, mind-body medicine, and mindful practices in medical training, the past president of the International Association of Medical Science Educators, former board member of the Association of American Medical Colleges. That one, it reminds me of my late father, who was also a member of that medical college. Leadership roles with AMEE and the World Federation for Medical Education, and a visiting professor at 125 plus medical schools worldwide. Next slide. Today's session is part of the Cannabis Research Institute's public research series, an initiative designed to make cannabis science transparent, accessible, and collaborative. Each session brings in leading researchers and practitioners to share evidence-based insights on cannabis, health, and society, and to help build a shared understanding across disciplines and communities. The title of today's presentation is Medical Cannabis: Perspectives from a Clinician and an Educator. And with that, I will hand it off to Dr. Leslie Mendoza Temple and Dr. Adi Haramati.
Thank you, Reggie. Sorry to if there's any technical flubs on our end, but you mentioned the title was here, and I'm going to go straight for what we're going to talk about today. And I'm going to talk about the competencies themselves, which I did a few weeks ago for this forum as well. So we won't get in as much detail as last time, but I'm going to talk about how we came about this curriculum, the fact that it got published in JAMA Open Network. Any of you can access the full text, as well as a commentary that followed. And I'm going to remind the audience, or inform those who haven't seen this before, what are the 6 pillars of competencies for what we hope all medical students should know by the time they graduate. Keeping in mind that the audience is the medical student. We have residents and fellows and others, but it's a different stage of the education flora and fauna. And then we have Dr. Haramati talking about how public demand drives changes in medicine, drawing from experiences in integrative medicine and nutrition education experiences. And he's going to talk about challenges and opportunities for addressing and measuring or assessing these competencies in med school curriculum. As a highly experienced educator who has known this system in the US for decades, we're really lucky to have you, Adi. So I have this quote, I've heard this before, I just don't believe cannabis has enough evidence for me to recommend this to anybody. And what if that's true? Well, one thing is you still need to know what is this? We've got 74% of Americans that live in a state where marijuana is legal for either recreational or medical use. And we are on a tipping point with the change of cannabis from Schedule 1 to Schedule 3 that's been proposed, yet still, I think it still needs a lot of details ironed out, but things are changing. And so whether or not one believes it's useful, we now have a legal obligation to know this, because at Schedule 3, this changes so many things in terms of access and research. So whether you believe that it's helpful or not, we have to know all of its aspects and teach our students to be competent in it. And this prompted the publishing of this article to develop medical cannabis competencies through the Delphi process, which is basically an iterative process doing rounds and rounds of massaging a set of ideas that a group of experts agree upon. So every word, every topic that was put into the competencies were discussed online in 2 rounds by this group of distinguished panelists, including Dr. Haramati and also Dr. Ethan Russo, who is also on this call. If I'm missing anyone else, I apologize. Janester Wilson King also, I think, might be on this call.
Yep.
So we have our lead authors, and then just a background is this is in Tel Aviv, Israel, where we met for the first time after 3 years of Zoom calls and putting together 2 special issues on medical cannabis clinical work and also the education work for complementary therapies in medicine, led by Dr. Kathy Kemper, who is the editor. Dr. Tubi Zolotov at Albert Einstein and the RADAR Center. RADAR stands for Regional Alcohol and Drug Abuse Research at Ben Gurion University of the Negev in Israel. To me, there's Dr. Misha Kogan at George Washington University, Center for Integrative Medicine, also a geriatrician and has written several books on cannabis and geriatrics. And Dr. Richard Israelowitz, who is our mentor in all of this from the Radar Center at Ben Gurion. So much credit to this. This team has put together quite a bit of work, and the JAMA Open Network article is a culmination of some very hard work. And these are the Delphi members. So if you can see, just looking at the specialties, if you recognize some names here, great. We have everyone from addiction medicine to family medicine resident, pre-medical student, internal med, geriatrics. We had someone from the NIH, NCAM, neurology, nursing, OB, oncology. We even had industry and communications to weigh in on this with no other influence from them. But, it's very hard to know cannabis without some of that insight on how the stuff is made. Peds, pharmacy, public health research, social work, public health, and toxicology. So you could see it's just a very diverse group, as much as we knew within our networks, as much as possible to get a very well-rounded Delphi program here. And it had to be large enough, but small enough to be nimble, so that our methods, which were from February to October 23rd, included 23 experts, as you saw, with a broad range of experience, 2 rounds of anonymous web-based surveys, so no one knew who was saying what, so you could be as objective as possible. And then we revised and revised iteratively by the Delphi team and then the research team to make sure that what we came up with was solid. final inclusion of competencies had to reach agreement. So we rated a statement, and then from 1 to 5, if you agreed greatly with this or strongly with the statement as is, the higher the number, the more agreement there were. And because we reached agreement in just 2 rounds at strong levels, that they were included, so we didn't have to keep doing more and more Delphi rounds. So that was nice. And this is the culmination of this. And I'm just going to go over the competencies, not the sub-competencies, because there's so many. We talked about that in the earlier lecture, which is recorded on CRI's website on YouTube. But number 1, you've got to know the basics of the endocannabinoid system. And we're honored to have Dr. Russo here, who's like a major author. And, that's where I learned about it, watching his talks, listening to his lectures over time. 2, we got to understand the main components of the cannabis plant and their biological effects. Understand the legal and regulatory landscape of cannabis in the United States. Number 4, to look at the evidence base for health conditions commonly managed with cannabis. Now, this doesn't mean there's evidence, but we know that cannabis, people use it for a whole lot of conditions. But what's the evidence base for that? And we intentionally left this very broad because your patients are going to come in with, I'm using cannabis for my XYZ, and you look for research on it, and it may have decent research or zero research, but we got to know where that is and that's going to be probably number 4 is the most dynamic one that's going to change a lot as soon as we can get more research going with the change in schedule status. It's going to take time. Number 5, understanding the potential risks of medical cannabis use or recreational cannabis use. That's pretty well understood thanks to the National Institute on Drug Abuse, NIDA, which has studied this extensively, along with alcohol and other substances. But we need to understand that as healthcare professionals. And finally, understanding basic clinical management with medical cannabis. This is also an area that will probably be pretty dynamic, as currently what people are using are best practices and figuring things out one-on-one with patients. There's no set protocols really for much, except for the pharmaceutical derived cannabis products that are out there. So these 6 pillars are what we want to expose medical students to, varying levels of intensity depending on the institution and the experience of the faculty. So this, following our article, actually published the same day, Adi and I, our colleague, Dr. Darshan Mehta from Harvard, published the commentary, and the quotes in there are just zingers. But I love this one. I'll read it to you for those who are just listening in. Quote, the competencies proposed by Zolotov et al. Should be mandated and integrated, not relegated to optional electives. Medical schools and residencies must embed cannabis training alongside opioids, benzodiazepines, and insulin, not as an afterthought, but as a core clinical domain. And I would say that's a really strong statement. So we will see how that's going to pan out. So this is going into Dr. Haramati's presentation. And from here, I will have you take over, Adi, and then I'll take over afterwards.
You need to stop sharing and I could start sharing.
Okay, I will stop sharing. That would help.
All right. Gives us a minute to look at everybody. And we're playing ping pong. So let's see if this works. And let me go full screen. Just give me the okay that it's a full screen.
Right.
We're good?
Yep.
Okay, great. So thank you, Leslie, for that background. Now we're going to switch from the clinician to the educator. And my involvement in this project has really been to try and provide an educator lens all along. And ultimately, what we want, of course, is to integrate the material into the curriculum for our trainees, both medical students and residents, as appropriate. But what I'd like to do in this, let's say 15 or 20 minutes, is give you a perspective on how do you actually do that. And so I'm going to draw upon 2 other movements that have happened in the last 20 years. One is the complementary and integrative medicine movement and how that's moved into the curriculum, because there are lessons to be learned from that. And the second is something that's happening right now, which is the push by the government to mandate an increased treatment of nutrition in the medical curriculum and how we're dealing with that. And so I'll spend some time on the public demand, on advocacy, on the role of public policy in really moving the agenda in medical education. And then I'll spend a bit of time just highlighting some of the challenges to doing this integration, and then what opportunities may present itself with a call to CRI and the University of Illinois, perhaps, to take a lead in this. So the competencies have been published, right? Leslie just shared that with you, and the big question is what happens now? It's not like deans will grab that article and say, okay, now we got to change what we're doing. The fact is it's complicated. So let me start with some lessons from the alternative medicine, integrative medicine world. And I'm showing a picture of Tom Harkin, the senator from Iowa, because in 1991, he was instrumental in pushing an agenda at the NIH. And what he did was he insisted that $2 million be allocated to create the Office of Alternative Medicine. The NIH was not in favor of this, but he predicated their budget allocation on creating this minuscule allocation of $2 million. Remember, the budget at the time for the NIH was probably 30 billion, not million. So despite the skepticism from the scientific community, the office grew and funding, and then by 1998 it became a center, and the budget moved to about 50 or 60 million. And then more recently in 2014, it shifted names again. It's now the Center for Complementary and Integrative Health, not just focused on medicine, but on health. And the budget is roughly in the $125 million range, while the NIH budget overall is about 50 billion. But this was a key piece, and this was driven by Harkin's own personal interests, but also that of his constituents and other constituents. So here's a timeline of what's happened over 25 years in integrative medicine. And I'll start with the center at the NIH, which was started in 1998. Now, what that led at the same time to the formation of a consortium of academic centers for integrative medicine. We officially formed in 2002. I had the pleasure of serving as the first vice chair of that group. We started with 8 schools, I'll show you in a minute, and then we've grown now to over 80 institutions. But that was a seminal movement because that began to bring the medical schools together and the deans together and the folks that are actually going to be the champions at their institutions to drive integrative medicine into the curriculum. In 2004, just as a timeline, again, I picked these things. They're not the only things that happened, but the Veterans Administration began offering chiropractic benefits in 2004. That was a big step. 2005, the Institute of Medicine convened a committee to look at CAM use in the United States, and that report was issued. I'll say something about that in a minute. And then the consortium, yes, its logo changed, but it began to have research conferences that were very high level. I had the pleasure of chairing 4 of those conferences, the first 4, in 06 and 09, and we'll have more scientific conferences, again, developing the evidence base. I also put this in 2007. At the largest research hospital in the world, the NIH Clinical Center, began an integrative medicine consult service. And so when you're looking to see how mainstream this is becoming and how it's not out there quite as much as it was in the early 90s, this has become now a consult service that other hospitals began to adopt. Another Institute of Medicine Summit report on integrative medicine and the public health happened in 2010, again, solidifying the need to increase education in the area. And then the consortium again evolved again. Now it's integrative medicine and health, and we have a whole series of conferences that build on that. The first World Congress on Integrative Medicine held in 2017 in Berlin. And then here, you can't probably read that. I'll read it to you. The role of non-pharmacological approaches to pain management, a workshop that was put on by the Association of American Medical Colleges. And so you're seeing here, and this timeline ends in 2020, mostly because I ran out of space on the slide. But the fact is you're beginning to see how this is evolving from the original formation of the center at the NIH. This is a slide depicting the rise of the consortium from a group of 8 institutions pre-formation to now over 80. Again, this slide ends in 2019. That was 7 years ago. We're now over 80, and pretty much every major university is now a member. But what about the education side? So the consortium team put together an article in Academic Medicine, which is probably the most widely read and prestigious journal in academic medicine around the world. And in 2004, read you the title, Core Competencies for Integrative Medicine for Medical School Curricula, a proposal. That was 2004. And then this article came out in 2015 that has to do with core competencies in integrative pain management for entry-level primary care physicians. If you're entering primary care as a resident, that means this is what a graduate needs to know about integrative pain management. This is also a core team that was from the consortium. So articles are being published on competencies that we expect our students to be able to master in this field. In 2005, the Institute of Medicine issued a report on education, and this is the recommendation. The committee recommends that health profession schools, that is medicine, nursing, pharmacy, and allied health, those are the professions for the Institute of Medicine, incorporate sufficient information about CAM into the standard curriculum, not necessarily so they practice, but to enable licensed professionals to competently advise their patients about CAM. And you see the parallel to what we're suggesting for medical cannabis in our competencies article, which is, it's not that every physician is necessarily going to be an expert on cannabis, but they ought to know enough so that they could advise their patients of who to see. And the interprofessional part of this is a key one. The NIH in 2001 issued 15 education grants. There were 5-year, the first 3 years, there were 5 a year. These were not $50,000 grants. These were $1.5 million over 5 years. This was a real investment. And this these were model programs that began to develop the incorporation of complementary and integrative medicine in their curricula. And then in 2007, we published a special collection of 9 articles in academic medicine about the experiences from these programs. So you see how this becomes mainstream. You also see how many years it takes to actually get there. But it's a combination of interest, champions at the schools, the NIH funding these initiatives, and then the schools going along. If it wasn't for the grant money, they wouldn't have moved so quickly. So that has a big effect on this. So the lesson, before I go to nutrition, so the lesson out of this is you need a combination of advocacy, public interest, champions at the schools, investment by NIH and other bodies, and then you have to publish what you're doing so that it gains credibility. Let me switch to nutrition because this is happening right now. If you're paying attention to the news, you know what's going on. So it all started 3.5 years ago with this bipartisan resolution. Senator McGovern from Massachusetts and Congressman McGovern and Congressman Burgess from Texas. And what they called for was a bipartisan resolution that medical schools need to enhance education for students and residents in nutrition. It was non-binding, but there was a veiled threat, which is unless you do this, we're going to look very carefully at your allocation for your residency programs. Nobody likes to be forced into a corner, certainly not medical schools, but 3 organizations began to take this seriously. Certainly the Accreditation Council for GME, and based in Chicago, this oversees residency programs. On the right is the AMC, which oversees medical schools, and ACOM, the American Association of Colleges of Osteopathic Medicine, and they came together to create a summit on medical education and nutrition. Now, I happened to be at this meeting, and my friend David Eisenberg was at this meeting, and this meeting dealt with 2 days, sessions on identifying, assessing competencies related to nutrition in UME and GME, which is undergraduate and graduate medical education. And so it was really more of a state-of-the-art, where are we? What came out of that was a report which doesn't really move education, but this came out of that. A year-long effort led by David Eisenberg and 37 of us to develop a consensus statement on proposed nutrition competencies. Now, this is not new. There were, in the literature, 354 competencies that have been published in various publications. about what medical students and residents needed to know. But this effort was to consolidate that into 36 out of 354 and try to get a handle on this. And this has become a blueprint for, frankly, what Senator Kennedy is now pushing. They took the 36 from this paper and they added another 35, so they have 71 that they've been sending to medical schools. But this has become the basis for the conversation. Now, let me just point out that this paper came out in October of 24. 2 months later, there's an election. Donald Trump gets elected, and Robert Kennedy is named the Secretary of Health and Human Services. He didn't waste any time. And in August of 25, so that was what, 5 months ago, 6 months ago, sends a letter to medical school deans demanding, the word here is demanding, that there be reforms in how medical schools and residency programs address nutrition in the curriculum. And what they called for, first he wrote an editorial in the Wall Street Journal, but in essence, what this is about is that they're calling for nutrition education requirements to be embedded in pre-med, in medical school curricula, on the licensing exams, residency certificates, and even in continuing ed. So there's a very hard push here. Look, you got to do more, and you have to do more. Now, when we wrote the paper on the competencies, we had no idea that this would be coming. But as we were thinking about the competencies, our plan was to develop the next step. And the next step is, once you have the competencies, to basically scour the nation and say, so how are people dealing with it now? Because there's plenty of nutrition education going on. And to say that there's no nutrition education is simply wrong. The real question is, what are they being trained to do? And is it the skill set that needs to happen? Turns out that most of the effort is on knowledge. Not a whole lot is on skills and counseling, and even less is about the understanding of food and behavior change. So there are ways in which we can improve nutrition education. And so the idea that David Eisenberg, myself, and the team from the Teaching Kitchen Collaborative was we're going to convene a 2-day meeting to look at best practices and then share those and summarize them in a report and disseminate it. And so in September, so remember, in August, the letter goes out from Senator Kennedy to medical schools saying, we are demanding that you do more. We had already planned through the Teaching Kitchen Collaborative, which I sit on that board. Think of this as an analogous to the consortium in integrative medicine. This is the group that's really driving nutrition education. But we teamed up with the AAMC and the National Board of Medical Examiners to issue a call for applications to present at this 2-day meeting that will be held at the AAMC. And so this went out. The deadline for this, you can't read, but I will tell you, was November 15th. And while we only have 20 speaking slots, we have 90 applications before us from across the nation. Some are very impressive. Now, today's February 2nd, today the letters went out to 20 of those individuals that their applications have been accepted and that to confirm that they're attending. And we have 3 that are backups in case not all 20 could make it. So we're moving forward very rapidly with this convening as the next step of implementing what's going to happen, that is bringing the competencies in nutrition to life. So now let me turn to the issue of medical cannabis. And as Leslie pointed out, we have the proposal. There are 6 competencies. They're highly manageable. But the question is, how do you actually implement? So there are a couple of challenges, and I'll just go through 5 of these bullets, right? The curriculum is packed. We all know that. So before, most deans will tell you, if you're going to add anything, you got to tell me what's being taken out. So one way to, sidestep that issue is to simply say, well, we don't have to add a new standalone course. What we can add is incorporate things into what's already being taught. But what we do is we make an addition and we add a piece here so that it's not time consuming. It's actually rich in a way to broaden that topic. So that's one way to deal with this. Who will teach if there are no faculty who are comfortable with this topic? Well, this is why we need to have CME courses. This is why at many of the med ed conferences, we have to have workshops on this and begin to disseminate what is the core knowledge that our faculty need to be able to convey. Competencies themselves require more than knowledge acquisition. It's about knowledge application. It's about counseling skills. It's about attitudes towards how people are using this. That is part of what we want people to be able to do, our medical students to be able to do. And certainly there has to be a consideration of what depth of knowledge is for students and what for residents. Family medicine residents are very different than surgeons. Um, and are there going to be fellows that are going to be much more skilled in all this? And then finally, a key piece, which Leslie mentioned at the last lecture, there's a lack of items of cannabis on licensing exams, and nothing drives the curriculum more than assessment. And putting questions on the licensing exams will ensure that this becomes part of the curriculum. So those were some of the challenges. Let me give you some of the opportunities. And I hope there are folks on this webinar that are involved in medical education, because I'm going to give a couple of suggestions here. I do believe that the material that we're talking about can be easily integrated, some of it into pre-clerkship courses, like pharmacology and neuroscience when we talk about pain, some of them into clerkships. Certainly pain management and many of the clerkships can handle that, rather than creating a standalone course. In fact, the standalone course is dead on arrival. That won't happen. Consider a curricular thread throughout the 4 years that's revisited. Cannabis may be introduced in pharmacology and in neuroscience and then picked up later on as the students begin to realize where this all fits. There's an opportunity to create creative skills, clinical skills training and assessment. An OSCE is an objective structured clinical exam. This is how we currently test students' ability to interact with patients and do a history and engage in a treatment plan, and how they communicate. Adding an element of cannabis into the material within that OSCE scenario is an easy thing to do, particularly if we're dealing with a patient with chronic pain. There's also opportunity to discuss regulatory and policy issues that every medical school has, and it would be another 15 minutes of, say, to add content. And frankly, I think that this is an important topic to enhance patient-provider communication and shared decision-making, a topic that students need to visit in a variety of scenarios. So if I go to my last slide, if we look at the competencies in medical curricula and we think about this, yes, there are challenges, but I believe there are also wonderful opportunities to advance medical education goals incorporating cannabis, not just for cannabis's sake, but for the skill set that we want our students to acquire, such as communication and patient decision-making sharing. So this is my last pitch. If any of you at the University of Illinois are educators, maybe it's time to convene a best practices, just like we're doing in nutrition at the AMC. But given that CRI is located here, maybe this is the place to do that. And with that, I'm going to stop sharing and turn it back to Leslie for her final set of slides.
Great, thank you very much. That's all right. And our juices are flowing on the idea of doing a conference. We've spoken about that before with Reggie and Christina and Quetzali. So, all right, here we go. So I went ahead and looked at how would you incorporate this? You know, Adi's talking about don't have a standalone course, things that are dead on arrival will be, it's just a time waster, but it really makes sense to incorporate the endocannabinoid system and treatment in throughout all 4 years. It just becomes part of the fabric of what a medical student learns. And this is the med school curriculum at UIC. This is from your website, years 1 and 2. You could see many areas here where cannabis or the endocannabinoid system can have some sort of role, just needs to be added in and hopefully should not be too onerous for whoever is planning curriculum. And as someone who's taught in the medical school, every time you have a slide deck and you're going to teach about pain, you have to, as an educator, get the latest. You are obligated by your own ethics to update. But if the conscientiousness of I need to incorporate something regarding cannabis and endocannabinoid system comes in, then this will be a refresh. This will be requiring effort on those curriculum planners, but now they have a framework to work from. In year 3 of medical school, this is how everything's divided up. You got 2 months of medicine, internal med, dealing with adults, surgery, neurology, family medicine, OB-GYN, psychiatry, and peds. So that's all the 3 years you focus on the specialties of, or actually primary care, mostly specialties. There, some of them there. I'm a family medicine physician, so if you're going to spend 6 weeks with us, this is really what you're going to learn about, and this is the National Family Medicine Clerkship requirements if you're a third-year student. Take a look at these chronic conditions. Anxiety, hello, cannabis can be good or bad for that. Arthritis pain, asthma, COPD, considering the effects of inhaling and vaping and smoking, the effects of cannabis on chronic back pain. We can just go down this list and I can generate 3 slides per topic, at least on actually every single one of these conditions. Even osteoporosis, osteopenia, I don't want my patient to fall. I think about dizziness and side effects of cannabis, but I can think of things that are therapeutic and adverse in all of these. There's many opportunities to teach. It just needs to be incorporated. And so there are also some other areas, and as a family doc, we are about prevention and wellness. So we have to learn about how to take care of sprained ankles and your physicals and take care of your immunizations and make sure your child is growing at the right velocities. So there's a lot of things in family medicine we have to know. We call ourselves the jack of all trades, the master of none, but hey, you know what? We should be knowing a majority of the conditions that walk through or issues that our patients walk through the door for us in a very short period of time. So that's another challenge yet to be determined. But cannabis education curriculum fits with all of the topics on this list to some degree, in addition to current standard of care. That's just family medicine, okay? Think about internal med, neurology, surgery. What do you do in the post-op? How do you help those patients get through post-op pain, for instance? So I'm going to re-emphasize what Adi had talked about is you got to quiz people on it. And one thing I think could already get started over time is a question bank for what is the endocannabinoid system. Whenever I write questions with the 4 multiple choice, takes a lot of time because your questions as an educator have to be airtight, or you're going to get angry students saying, why did you mark me wrong? So you have to be, these are the kinds of things we could probably be preparing ahead of time. And then you almost can retroactively plan your slide presentation or whatever you're teaching your student based on the questions you generate. And you have to make sure that you periodically review them for fidelity to the evidence base and modify them as we learn new things. So in terms of future steps, I also want to reemphasize the interdisciplinary need to increase the other health professions' knowledge base. So those in mental health, for sure, nursing school, pharmacy school, the rehab services of PT and OT, and social work. And let's not forget industry. Our cannabis dispensary staff, they need to really continue to grow in their knowledge. They are the entry point for my patients. They're getting medical advice at the dispensary, and in Illinois, they're not medically trained. They're not required to be. In other states, there are dispensary staff are required to have some sort of health professions degree, but that's not happening everywhere. And so this is a very, very good opportunity to improve the safety and efficacy of cannabinoids when they're being used therapeutically or recreationally. So one last great quote from Dr. Mehta is that this is not just reform. It's a reclamation of our professional mission. Physicians are healers guided by evidence and oath, not outdated legal definitions. A delay in clinician preparedness translates into preventable harm, perpetuated stigma, and a failure of trust. The consensus statement by Zolotov et al. Consensus has arrived after years of delay, but it inspires a call to action and a roadmap. We now must act. Medical cannabis is here. Will physicians catch up, or will we, through omission, continue to let patients navigate therapeutic uncertainty alone? And I propose that we don't let that happen. Wanted to thank the Cannabis Research Institute for the opportunity to present this my team at Endeavor Health. We are located in Glenview, and the Endeavor Health Department of Family Medicine and the University of Chicago, particularly the mentorship I've received from Dr. Janice Benson and Wanda Cruz Knight. I know I'm forgetting folks, but thank you so much for your support. And we are excited to hear your genius ideas here. So at that, I will stop sharing my slides and see if there are any topics that have come up in the chat, or if people, I'll let Quetzal, if you want to moderate, or Reggie, if there are any questions or comments you want to go through.
And I've got some stuff that's come up in previous conversations, but Ethan, take it away.
Sure. So for Leslie and Addie, I wonder what you think the possibilities are for electives, specifically on cannabis and the endocannabinoid system in medical school and or residency programs.
I'm
Is
happy
that
to
a
talk about-
valid
Yeah.
approach to take?
Right. So I'm happy to talk about medical school. Many of the schools have opportunities for electives, but the one I want to talk about is something called a deep dive. So usually after the clerkship, so the pre-clerkship phase is anywhere from a year to a year and a half. Most schools have shifted from the 2-year plan. So, and then they start their clinical rotations, and that will go about another year, sometimes a year and a half. So that gives the latter part of the 3rd year and into the 4th year the opportunity to create a deep dive. Sometimes it's 2 weeks, sometimes it's a month on a very specified topic. Many times they're integrated with basic science and clinical issues. The school that does it the best is Vanderbilt, but there are many, many other schools that do it. We do it at Georgetown, have deep dives on specific topics. That would be a way to start. Because you're getting well, there's pros and cons. The pro is that you get into the curriculum and you begin to interest students. The con is that you're only getting the students that are interested, and you're not really addressing all the students that need to know a baseline. So they're getting a little more enhanced knowledge, but it's a subset of folks. And so I think it's a trade-off. But anything that you can do to get in is a good thing. You might want to say something about the residency program, Leslie.
I think we have in the residency things like tracks. And I wrote in the chat earlier that integrative medicine physicians and clinicians are the entryway to cannabis. We are the gateway drug, I guess you would say, the most open-minded, the most forward-thinking on all of this. I know there are others who are not saying they're integrative, but most likely you'll get that kind of traction if they do an integrative medicine rotation. And it also depends on the attending. So if you have an institution that doesn't have a local expert, it's hard to have a deep dive when you don't have a faculty member to teach. So you may have to do these like supplementary kinds of trainings. I know like Society of Cannabis Clinicians is around and they have very rich curricula. How might that work where you go to another institution and do virtual training and give the student credit for doing an elective to make that possible and to count. So I think that's very much a great idea. It's something that's going to have to be figured out on an institution by institution basis. But I don't, if you had an endocannabinoid medicine track, it would be coming from a highly specialized place that has a deep enough pocket of clinicians trained to provide that information. So you're only going to have a handful of institutions that would be able to do it. For instance, like let's develop UIC, as Dr. Harmadi was proposing, having some sort of, consortium extravaganza of like bring the best and the brightest on a regular basis to make it a center. So I think we have other questions have come up. Christina, you said you had some.
I do, but we also have another question in chat from Amani, and she, excuse me, said, as a dispensary agent or bud tender, I would love more medical cannabis education integrated in the responsible vendor training. how would you go about getting those competencies included? And then she just specified that the RVT is an annual training required for folks who work at a dispensary, a licensed dispensary.
I think from having known that in the beginning when cannabis came about in Illinois, I saw this brief push from education groups trying to be the one that was the vendor for whatever dispensary purchased their educational suite. And I don't know if anything has advanced from that point forward, but there may be opportunities on a state level where we're offering something that is really robust, not funded maybe by something like CRI's initiatives to augment what's already out there for the dispensary staff in case because I know that there's different types of curriculum available. I'd love to know from Imani, like, was it an 8-hour class you attended? Was it 4 hours? It's once a year. What's required of dispensary staff to keep up their license to be able to sell cannabis? That's also an area that has a lot of opportunity to augment and improve, especially if you don't get a lot of endocannabinoid system stuff in there. You should, including interactions, drug interactions, at least knowing when to refer and tell the patient, your customer, hey, that question's a little bit out of my pay grade or my league. You need to talk to your physician about this, and to know how to triage properly, because there's a fine line of practicing medicine in the dispensaries without a license and giving valuable advice. You want to be helpful to your customers, but you don't want to overstep the knowledge base. So I think that's a good call for improving in education.
Thank you. And she did, she just added a little detail. And Amani, if you, I don't want to put anyone on the spot here, but you're welcome to jump off cam if you'd like, but you're engaging in chat, so I'm guessing you might not be able to. But Leslie, she did indicate it's once a year and it's about 2 hours, and she reflected it's kind of short there. So, but Amani, I don't want to speak for you, so feel free to jump in if you're able. I'm guessing she might be like between classes or busy.
Oh, she's under the weather. It's okay. Thank you.
Sorry.
All right. I think we get.
No, you did a good job.
We've got other questions too, I see in the chat. Where do you want to go with this, Christina? Who should we address next, or Reggie, or?
I kind of like TJ Johnson's question that you might want to handle. Hey, I'll read it to you. What do you think of the chances are of getting nationwide training requirements getting integrated into current curriculum after cannabis becomes Schedule III?
Mm-hmm.
And do you think recommendations for leaning on legislators to push for this to become a requirement?
Adi, can legislators, I don't think they can mandate what's in, well, they have with nutrition, basically saying we're going to pull funding if you don't teach nutrition. That's why we have you talking about this, because we're having a live laboratory of this happening right now.
Well, I think the essence of the question is when it becomes more available as a substance for patients to take, does that make it easier for us to convince schools to incorporate it? I think the answer is yes.
It also, though, assumes that we will reschedule to Schedule III, and that is an unresolved issue at the federal level still.
It's not finalized yet, but yeah.
Well, maybe you can illuminate it for me. How does that process become? Who decides?
Oh, this is a whole other series of conversations, but the short of it is Reggie's laughing because he's like, oh boy.
Oh boy, here we go.
So the short of it is there was an executive order issued that directed the AG to expedite the reschedule process. So it was initiated and then paused is the very short answer due to appeals and indication or suggestion that the DEA, which oversees the scheduling process, had engaged in ex parte communications or communications that did not involve all parties by way of responding to folks who were taking an anti-rescheduling or anti-cannabis position more favorably and giving them information to help them change their request for a hearing as part of the established rescheduling process. It's jammed up in appeal with an administrative law judge as part of the DEA, and it is going through the rulemaking process, which is bound by the, are there any attorneys or regulators? It's the American Procedures Act, which dictates rulemaking for federal legislation. So the short of it is it's jammed up in appeals internally with the DEA, who has historically taken an anti-cannabis position.
And is now currently headed by somebody who has publicly stated that he's anti-cannabis and feels that cannabis is a gateway drug. Sorry.
So, yes, but the appeals, the process was stalled before that person was
Yes.
installed at the DEA. So there's a bunch of different things going on, but the actual short of it is we're jammed up in rulemaking.
So-
And the people who have the ability to get us unjammed are, to Reggie's point, led by a group of folks that are not necessarily supportive of cannabis.
So as someone who's not really involved in the field as much as looking at this from an educational standpoint, I don't think that moving to Schedule 3 is necessary to move this into the curriculum. That's the flip side of your question, TJ. There are enough people using this that the imperative for our medical students and our physicians to be able to advise patients is there.
DJ makes the point too from that slide I had of 74% of Americans, 3/4 of the country has access to it. So it's, come on.
I'm curious if you agree, TJ, if you want to unmute and just give us your opinion.
Hey guys, yeah, like that last comment, if 3/4 of the nation have access via recreational or medical market, that's a lot of people that have access whose physicians are just lacking ECS knowledge and cannabinoid knowledge in those medical curriculums. So yeah, how we, start mandating or requiring these medical curriculums to integrate some ECS in there. That's really kind of the bulk of the question. How do we get there?
I think you have multiple forces. You've got that, and then you've got the Schedule 3 looming, which is messy. But as Adi has mentioned, public pressure. I mean, how did we even get integrative medicine into the foray? It was a $2 million grant from, Harkin that started everything. So we're, I always like to look at things like 5, 10, 15, and 20 years from now. This discussion is going to be, one of those like the groundbreaker, like we're finally in mainstream medical education. Now it's 10 years from now, the students have gone through their residence already. We're not fighting those uphill battles right now. We're in the catch-up mode. At that point, what kinds of advances have been made in the research. It's going to be exciting, but just know that this is the ground level when it comes to putting it into mainstream medical education. We had to start somewhere with the competencies, and nutrition is just a great example of how things are getting done. Because I can't tell you how many times my patients, with 100% of people exposed to food, and your physician doesn't really advise you well on what to eat for your heart attack. I mean, we have some basic things. We have basic education, but goodness, the catch up on nutrition alone, look how long it's taken. So this is where like the cannabis piece, I think, is being accelerated because now we're learning from the lessons of how you make change in nutrition, mainstream medical education. People wonder why doctors are always so behind on what you might hear on TikTok and social media. And a lot of that is, a lot of crap out there. And there's also a lot of truth. But by the time it filters into the medical curriculum, you can see what kind of steps it takes. I think it is good to be, more conservative, not give into trends too quickly. But there's a point where like, gosh, this has been really, really slow. And we are working on advancing what has the evidence base, and we want to do it smartly. So thank you for those points, TJ.
So, Kinzelli asked a really good question, and I want to pick up on that, which is, she says, if we could reconvene, why don't you ask your question? I don't have to read it for you. Just tell us what you want, and I'm going to answer it.
Yeah,
We
of
have
course.
a minute
And
left,
then,
yeah.
yeah, we have a couple minutes left, and I know Alexis Mueller also posted something below that I think we should definitely have, would love to address if we have time. But what I was asking is, if we reconvene in 5 years, what would tell you that medical cannabis education has arrived in health professions training? Like, what signals should we be watching for now, or what would signal the arrival at that point?
So there are two things I'd say. The first is in the graduation questionnaire for medical school, the AAMC asks on a number of topics, how well do the graduates feel they're competent to address X? Nutrition is one in that. But if we had a question about medical cannabis, how well do our graduates feel they could advise patients about it? That would be very telling. The second is, are there any questions on the USMLE step 1 or step 2? That's going to be telling as well. So those are two areas that we could work on. What I would say is one way to get there, and I want to say another word about the convening, is for an organization like CRI or to team up with the School of Medicine to hold a day-and-a-half session on best practices in educating in medical education and cannabis. And hold it, invite people to come to it and say, give us your best thing. Tell us what you're doing, either in UME or GME. And then that gets advertised throughout the network that this medical school is teaming up to hold a session about this. That will get people's attention. And that's how you keep it moving. It's going to need philanthropic support. And so those out there that have connections to support a meeting like this, it could go a long way.
Great. I know if anyone wants to stay on because we're at time, but I see Alexis Mueller from Hawaii is on, and she's written about trying to, in their curriculum, there's plenty, and I said that earlier, a lot about the harms, there's plenty you can present, has a lot of evidence base, but not much about the therapeutic values. Is there any education out there that we can use to help move the needle forward to keep engaging the conversation of how this education is important for med students? And they've launched 200 free CME on medical cannabis to all their medical professionals in the state, which is that's how you do it. If you get like 20 people to come, you have to keep doing it over and over again. And that's how change is made. People aren't just going to all rush to it right away, but you keep on working on making it easy to get. Like today, these ideas will just take root the more you expose. There's no one way to do this. And I love your idea, Adi. Now we have some meetings about that.
So I just want to jump in here because we're a little over time right now. So I'm gonna say thank you for joining us. At CRI, we believe that science should serve the people, policy, and the planet. Our work is rigorous, community-centered, and grounded in equity with impact at the heart of everything we do. So these are the ways that you can stay connected with CRI. And, if you subscribe to our newsletter, visit our website, we will have not only this particular presentation, but all the previous presentations, including the one from Ethan Russo. And then also, that's also a good way if you have questions or potentially other topics that you'd like to see us investigate. That's a great way to get a hold of us as well. We hope to not only continue this conversation, but hear from all of you and see you at future events. Thank you very much.